Okay, welcome to this first in a series of e-seminars arranged by the ERA-EDTA to help improve education within the nephrology community and hopefully beyond. My name is Kate Stevens and I'm moderating today. So a very short introduction. We are delighted to be able to offer these e-seminars covering a wide range of topics. So hopefully there will be something for everyone. A couple of very quick points. If you missed the live events, most will be available on our YouTube channel, and so make sure you subscribe. You can do that below if you're watching this on catch up. Today, if you have any questions, please ask them in the Q&A facility and we will do our best to get through as many of them as possible. This is one of 3 sessions focusing on new pharmacological therapies in diabetic kidney disease. The sessions are supported by an unrestricted educational grant from AstraZeneca, for which we're very grateful. Today's session asks the question, SGLT2 inhibitors and CKD, are they drugs for everyone? So let's find out. It's my pleasure to introduce our speaker, who will be familiar to the vast majority of you, Prof. Hiddo Heerspink from the University of Groningen. And we also have 2 panellists, Prof. Gert from Innsbruck University and Prof. Christoph Wanner from Würzburg University, who of course is also the ERA-EDTA president. Prof. Mayer has been involved in several of the SGLT2 inhibitor trials, including EMPA-REG, DAPA-HF, and Prof. Wanner is on the steering committee of EMPA-REG Outcome, EMPA-Reduced and EMPA-Kidney. Prof. Heerspink has been extensively involved in many or most really of the big trials in this field. He's a clinical pharmacologist and of particular relevance to today, he's on the DAPA-CKD Executive Committee as a principal investigator. And it's results from DAPA-CKD which he will present for us now. Thank you, Hiddo.
Thank you so much, Kate, for the introduction, and thanks to the ERA-EDTA for the opportunity to present this afternoon the results of the DAPA-CKD trial and to answer the question, SGLT2 inhibitors, are they drugs for everyone? Let's see how the results look like, and let's come back to that question at the end of my presentation. I'm now going to share my slides, and I hope this will work. It usually does. I hope everyone can see my slide. And I titled my slide, Extending the Use of SGLT2 Inhibitors from Diabetic to Non-Diabetic CKD, which already gives away some of the answer of the question, are SGLT2 inhibitors drugs for everyone? The answer is probably yes. So here are my disclosures. We all know that the burden of chronic kidney disease increases and the number of patients who require kidney replacement therapies are increasing over time. And this is illustrated in the graph on the left, which is a study published a few years ago in Lancet, which demonstrated that the number of patients receiving kidney replacement therapies increases, with the steepest increase seen in Asia, North America, and Europe. Another study demonstrated that the global age standardized mortality rates actually have decreased for a number of chronic diseases like ischemic heart disease, stroke, or pulmonary diseases in the graph on the right. In contrast, mortality rates for kidney disease have increased. So we see more patients requiring kidney replacement therapies. We see that the mortality rate increases, so we need new drugs to halt the progression of chronic kidney disease. A big problem is that the prevalence of chronic kidney disease is still undiagnosed in many patients, in particular in the United States. But there's also data from Europe that suggests that in many patients, chronic kidney disease is not appropriately diagnosed. What you see in the graph is on the y-axis the percentage of undiagnosed patients with type 2 diabetes. And if we stratify these patients according to the stage of chronic kidney disease, and we look in different years from 2011 to 2017, we see that chronic kidney disease stage 3A is still undiagnosed in about half of all patients. Even when we look at stage 4 chronic kidney disease, around 10% of patients have stage 4 chronic kidney disease, but it's not diagnosed in these patients. These are data from the United States, but even in the United Kingdom, only 40% of patients with microalbuminuria had a code for microalbuminuria on their record. indicating that there's still 60% of patients with microalbuminuria who do not have a code in their records. And this illustrates that we need to continue with efforts to emphasize the importance of diagnosing kidney disease, because if we do not diagnose it, we cannot treat it. Apart from this, we know already, and you know this as well, that chronic kidney disease is associated not only with kidney failure, but also with cardiovascular complications, in particular heart failure. This is a study published a few years ago that demonstrated that patients with heart failure, both with reduced or preserved ejection fraction and chronic kidney disease, had a much higher risk of developing heart failure. I should say actually that patients with chronic kidney disease had a higher risk of developing heart failure. And this applies when we look at eGFR on the left, but also patients with microalbuminuria had a much higher risk of developing heart failure, reduced or preserved ejection fraction compared to patients without microalbuminuria. Fortunately, we have drugs now available that reduce the risk of kidney failure and heart failure. And these are the SGLT2 inhibitors. The EMPERAC trial demonstrated for the first time, and it was actually Professor Wanner who demonstrated that dapagliflozin significantly reduced the risk of kidney failure. And these findings were then confirmed by the CANVAS trial, by the DECLARE-TIMI trial, and last year the CREDENG trial demonstrated that in patients with type 2 diabetes and chronic kidney disease, dapagliflozin significantly reduced the risk of kidney failure. What are the mechanisms for the protection with SGLT2 inhibitors? It appears that these effects are unrelated to the degree of glycemic control you achieve with these agents. And an often cited hypothesis is that these drugs normalize tubuloglomerular feedback. Tubuloglomerular feedback is a physiological adaptation of the glomerular tone in order to stabilize GFR under different settings of renal perfusion. So to illustrate this, let's suppose that we have a patient in whom renal perfusion is reduced. In that individual, there's less sodium filtration due to the reduction in renal perfusion. And so there's less sodium delivery to the macula densa. And this is sensed by the macula densa as a reduction in renal perfusion, which leads to a signal to the afferent arteriole to dilate. This will increase renal perfusion, this will increase intraglomerular pressure, and this will prevent a drop in GFR, which would occur if nothing would happen in the setting of a reduced renal perfusion. Now, in patients with type 2 diabetes, there's an upregulation of the SGLT2 transporter in the proximal tubule. And this is most likely an evolutionary response in order to retain all the glucose that is filtered in the body. But by reabsorbing glucose, we also reabsorb sodium. And thus, as a consequence, there's less sodium delivery to the macula densa, which is sensed as a reduction in renal perfusion, which leads to dilation of the afferent arteriole and an increase in intraglomerular pressure, which in the long term leads to single nephron hyperfiltration, onset of microalbuminuria, the first manifestation of diabetic nephropathy, and in the end, a decreased functionality of the nephron. Now, with an SGLT2 inhibitor, we actually increase the sodium delivery to the macula densa. And thereby, we normalize tubuloglomerular feedback, which leads to a constriction of the afferent arteriole, and thereby an acute reduction in intraglomerular pressure, acute reduction in GFR, which is completely reversible, even after years of treatment, and in the end, preservation of kidney function. And this has been illustrated in patients with type 1 diabetes, for example, already a couple of years ago. And in this study, David Cherney demonstrated that in patients with type 1 diabetes who were hyperfiltering, treatment with an SGLT2 inhibitor acutely reduces renal blood flow, GFR, and increases renal vascular resistance, which indicates that the afferent arteriole constricts. Could this mechanism also be applicable in patients with non-diabetic kidney disease? Well, actually, what do we know about hyperfiltration hyperfiltration and sodium reabsorption in the proximal tubule in patients without diabetes. This study, published 30 years ago, looked at control patients and patients with essential hypertension with a normal GFR, the light blue bar on the left, and patients who were hyperfiltering, the green bar. They, of course, the hyperfilterers had a higher GFR. But when we look at lithium clearance, which is a measure of sodium reabsorption in the proximal tubule, we see that these patients who were hyperfiltering had a decrease in fractional lithium clearance, which indicates that these patients reabsorb more sodium in the proximal tubule, just like the patient with type 2 diabetes. And these patients who are then hyperfiltering because there's less sodium delivery to the macula densa are more likely to develop microalbuminuria. As you can see in the graph on the right, these hyperfilterers, there's more, the prevalence or incidence of microalbuminuria is significantly increased compared to patients with normal filtration. This is when we measure microalbuminuria single time, but when the authors also looked at persistent microalbuminuria, they found similar data. Now, what about patients with obesity or with higher body mass index? What you see on the left is the correlation between body mass index and filtration fraction as a measure of hyperfiltration. And there's a clear correlation between the two, indicating that people with a higher BMI show higher filtration fractions and thus likely higher intraglomerular pressure and single nephron hyperfiltration. Similar data was seen in another study where obese individuals were compared with non-obese individuals. And again, what you see on the top graph is a higher filtration fraction, and on the bottom, you see a higher GFR compared to patients who were non-obese. So also in the non-diabetic settings with hypertension or obesity, there appears to be hyperfiltration. Now, can we intervene in that process with a proximal diuretic? Because in my view, SGLT2 inhibitors are just proximal diuretics. Well, we have one other class, which is also a proximal diuretic. And this is acetazolamide, a carbonic anhydrase inhibitor. A study demonstrated that in non-diabetic obese individuals who were hyperfiltering, the fractional lithium excretion significantly increased after treatment with acetazolamide, indicating that we block the sodium reabsorption in the proximal tubule if we treat with acetazolamide. This leads to an acute reduction in GFR, which you can see in the second graph, and a reduction in renal plasma flow and an increase in renovascular resistance. A similar pattern of effect that we saw in patients with type 1 diabetes who were hyperfiltering and treated with dapagliflozin. So perhaps this mechanism of SGLT2 inhibitors could also be applicable in patients without diabetes and obesity. Now, what do we know about the effect of SGLT2 inhibitors in a non-diabetic setting? Well, when the SGLT2 inhibitors were developed, there was a lot of discussion whether they should be used as diabetes-lowering drugs or whether perhaps they should be used as obesity-lowering drugs. Dapagliflozin initially was developed as a drug for obesity, so a body weight lowering drug. But because the company felt that the market would be better for diabetes during the development program, they switched to diabetes. But there were some studies done in non-diabetic obese individuals, and one of them is this study published in 2014, which demonstrated that dapagliflozin significantly reduced body weight and increased glucose excretion creatinine ratio. In this study, by the way, it was also shown that in these obese individuals, there's an acute reduction in GFR compared to placebo. So it appears that the pharmacodynamic activity is retained with an SGLT2 inhibitor. But what about the effect of SGLT2 inhibitors in patients with chronic kidney disease without diabetes? To answer this question, we designed the DIAMOND study. The DIAMOND study was a study in 53 patients with chronic kidney disease without diabetes who had a GFR on average of 58 mils per minute measured with iohexyl GFR, and all patients had proteinuria. The median was more than approximately 1,000 milligrams per day. The primary endpoint in this study was change in proteinuria. The secondary endpoints were mGFR, measured GFR, change in measured GFR, and albumin creatinine ratio. The primary endpoint was not met. Dapagliflozin in this population did not change proteinuria, but interestingly, as you can see on the left, dapagliflozin significantly reduced GFR by 6.6 mL per minute compared to placebo. This effect was directly present already after 3 weeks and was completely reversible when we stopped treatment, indicating a hemodynamic effect just as we've seen in patients with type 2 diabetes. The albumin creatinine ratio fell by about 28% in the dapagliflozin group, which was statistically significant on itself. But there was also a reduction in the placebo group by 15%, leading to a between group difference of 17%, which was not statistically significant. But maybe there was an effect because this was a relatively small study, and the 95% confidence interval did not exclude an effect of 33% reduction in albuminuria. Based on these findings, we designed the DAPA-CKD trial already a few years ago. SGLT2 inhibitors, including dapagliflozin, have shown favorable effects on cardiovascular and kidney outcomes in large trials. And studies which included non-diabetic populations suggest that the benefits of SGLT2 inhibitors may extend beyond those with type 2 diabetes, and therefore DAPA-CKD was designed to assess the effect of dapagliflozin on kidney outcomes in patients with chronic kidney disease, both with and without type 2 diabetes. And these patients were already receiving optimal care, including an ACE inhibitor or angiotensin receptor blocker. The primary outcome of the trial was a 50% eGFR decline, end-stage kidney disease, renal or cardiovascular death. And the secondary outcomes were a composite outcome of sustained 50% eGFR decline or more, end-stage kidney disease or renal death, a kidney-specific endpoint. The secondary outcomes were cardiovascular death or hospitalization for heart failure and all-cause mortality. And then we also had exploratory outcomes. We also looked at eGFR slope. And we looked at the total eGFR slope, which is defined from randomization to end of treatment. But we also looked at the chronic eGFR slope to exclude the acute hemodynamic effect. And the chronic eGFR slope was defined from week 2 to end of treatment. The DAPA-CKD trial enrolled adult patients with chronic kidney disease with an eGFR between 25 to 75 mL per minute and a UACR between 200 and 5,000 milligram per gram. We excluded patients with type 1 diabetes, patients with polycystic kidney disease, lupus nephritis, and ANCA-associated vasculitis, as well as patients who required immunosuppressive therapy. These individuals were randomized in a one-to-one fashion to dapagliflozin or matching placebo, and they were then followed for 2.4 years. The study was conducted in 21 countries across 386 sites and enrolled 4,304 participants. The first patient was enrolled in 2017, and then early this year, as you may have heard, after a regular review meeting, the independent data monitoring committee recommended that the trial be stopped due to overwhelming efficacy. And therefore, the steering committee accepted this recommendation. The trial closeout procedure started during the COVID pandemic, which was not easy, but we managed to find all patients, or nearly all patients, and the last patient last visit occurred on the June 12th this year. 4,304 participants were randomized in a similar fashion to dapagliflozin or placebo. During the follow-up, 10 participants discontinued the study in the dapagliflozin group. 8 withdrew their consent and 2 were lost to follow-up. In the placebo group, 5 participants discontinued study, 3 withdrew consent, 2 were lost to follow-up. So 99.7% of the population completed the study, and vital status was known in almost everyone except 5 patients. The baseline characteristics of the population are shown on this slide. The average participant was 62 years, 1/3 was female, 2/3 had a diagnosis of type 2 diabetes, so 1/3 did not have type 2 diabetes, and the mean eGFR was 43 mL per minute. This is the lowest eGFR on average that has been enrolled in a trial of SGLT2 inhibitors. The median UACR is close to 1000 milligram per gram, and nearly all participants used an ACE inhibitor or angiotensin receptor blocker. In 3% of the population, the drug was not tolerated, and these patients could also participate. And the primary endpoint was achieved in 312 participants during follow-up, and this was reduced to 197 participants during dapagliflozin, leading to a 39% relative risk reduction with a p-value that indicated a highly statistically significant treatment effect. The number needed to treat to prevent one event during 2.4 years follow-up was only 19, and this is actually much better than what we see with ACE inhibitors or angiotensin receptor blockers, and this effect was achieved on top of ACE inhibitors or angiotensin receptor blockers. When we then look at the renal kidney specific endpoint, there was a 44% relative risk reduction, 101 events, fewer events with dapagliflozin compared to placebo. And then when we look at the patient-oriented, clinically extremely important endpoint of chronic dialysis, kidney transplantation, or renal death, a clinically meaningful endpoint, we see a 34% relative risk reduction with a p-value of 0.0072. Now, an important question is, of course, whether these effects were present in patients with and without type 2 diabetes. So you'll see the results over here in the slide. In the top row, you see the effect on the primary endpoint in the overall population. And when we then stratify the population by baseline type 2 diabetes status, we observe that the effects are present in both patients with and without type 2 diabetes. Now, some people interpret these findings as if the effects are even stronger in patients without type 2 diabetes because the hazard ratio is 0.50 compared to 0.64 in patients with type 2 diabetes. I don't think we should interpret it that way because the p-value for interaction is 0.24, which indicates that the overall effects are actually similar in the type 2 diabetes and non-diabetic population. The effects are also consistent if we compare patients with a UACR above or below 1000 milligram per gram, and even if we look at patients with eGFR above or below 45. I know that in many countries, SGLT2 inhibitors are not indicated in patients with eGFR below 45. And this is because the regulatory agencies recommended not to use this drug because the efficacy of these drugs to lower HbA1c is decreased in people with a lower GFR. We now demonstrate that if we look at clinical endpoints, and that's why we're using these drugs, we want to prevent clinical endpoints, the effects are consistent in people with a low or high baseline eGFR. To answer the question whether SGLT2 inhibitors can be used by everyone or only by a selected population, we have pre-specified other subgroups. And I don't want you to look at every subgroup specifically, but look at the overall pattern of the effect. And what you see here is that the effect of dapagliflozin is extremely consistent in all these subgroups. And perhaps even more importantly, the effect is statistically significant in each and every subgroup. So to answer the question, can these drugs be used by everyone? Well, from an efficacy perspective, probably yes, but we should also look at the safety, of course. Now, what about the secondary outcomes? The secondary outcomes are shown here. There was a significant risk reduction for cardiovascular death or heart failure hospitalizations by 29%, and a significant reduction, a notable 31% risk reduction for all-cause mortality with a p-value of 0.0035. I started off my presentation that heart failure is a common complication of chronic kidney disease, and we here demonstrate that dapagliflozin does not only decrease the risk of kidney failure, but also of heart failure. It's also interesting to note that the DAPA-HF trial, which was published last year, demonstrated that dapagliflozin significantly reduced the risk of heart failure in people with established heart failure with reduced ejection fraction. Now, we demonstrate similar treatment effects, but then in a population with chronic kidney disease. And these findings are consistent with the recent EMPEROR-reduced findings that demonstrated that empagliflozin also significantly reduced the risk of hospitalization for heart failure in people with heart failure and a reduced ejection fraction. Now, what about the rate of renal function decline? consistent with other studies, as dapagliflozin in the DAPA-CKD trial caused an acute decline in heart failure of about 4 in eGFR of about 4 mils per minute during the first 2 weeks of treatment, as you can see. But then during prolonged treatment, there's a preservation of kidney function decline with a steeper decline during placebo treatment of 3.6 mils per minute per year versus 1.7, so almost 50% attenuation of the chronic eGFR decline. What about the safety? Well, the number of patients who discontinued study drug was similar between dapagliflozin and placebo, and the number of patients who discontinued study medication due to an adverse events were also similar, as were the proportion of patients with serious adverse events. We also pre-specified a number of adverse events of special interest, including amputations, fractures, renal-related adverse events, and hypoglycemia and volume depletion. And overall, the proportion of patients with these events was similar between dapagliflozin and placebo. Also noteworthy is that there were no patients on DAPA with diabetic ketoacidosis, and in the non-diabetic population, there was no major hypoglycemia reported by the investigators. Now, how does this change the landscape of clinical trials and in particular clinical practice? So I would like to bring you back to 2001 when the IDNT and Renal trials were published. These trials demonstrated that losartan and irbesartan significantly slowed the progression of kidney disease, but still there's progressive renal function loss during treatment with these drugs. And you can see that in the graph shown here, 5.4 mils per minute with irbesartan and about 4.2 mils per minute per year eGFR decline with losartan. Then when we look in the EMPA-REC and CANVAS trials, and we look at the placebo arm of these trials, and mind you, the placebo arm, these patients included patients with an ACE inhibitor or angiotensin receptor blocker, about 80% of the population. And we select from EMPA-REC and CANVAS the patients with a low GFR and a high albuminuria. We see that actually in the placebo arm, so the patient with ACE or ARBs, we haven't improved eGFR, the progression, or we haven't been able to slow the progression compared to 2001. But now, with canagliflozin and dapagliflozin, again, we see in the placebo arm rates of decline which are similar as those observed in 2001. But with an SGLT2 inhibitor, we are able to slow the progression of eGFR decline and to reduce the risk of kidney failure. So in patients with chronic kidney disease with and without type 2 diabetes, dapagliflozin compared to placebo reduced the risk of kidney failure, reduced the risk of death from cardiovascular cause or hospitalization for heart failure, and prolonged survival. Dapagliflozin was well tolerated in keeping with the established safety profile, and the effects were consistent across all pre-specified subgroups. In addition, these benefits were also seen regardless of background MRA use or diuretic use. And this is an important question that often comes up. Are these effects consistent in patients with diuretics? Because we know that many patients with kidney disease also use diuretics. And indeed, we found that dapagliflozin significantly reduced the risk of kidney failure, regardless of background use of diuretics or mineralocorticoid receptor antagonists. So to answer the question, can these drugs be used by everyone? Probably yes, by many, many patients, perhaps not so much by people in whom there's a history of diabetic ketoacidosis, in whom elderly patients at risk of volume depletion, I would be careful. But in all the other patients, I would recommend the use of SGLT2 inhibitors. I'd like to thank you for your attention, and I look forward to the discussion.
Thank you, Hiddo. That was a terrific summary of really exciting data for the renal community and beyond. So I'd like to pass over actually to Gert and Christoph just in a second, but if you don't mind, there's a couple of questions come through in the chat that I think you'll be able to answer quite quickly, if that would be okay.
Perfect.
And we will then come back to questions later. It's great that so many of you have put questions through. So is the number needed to treat that you quoted for DAPA-CKD primary outcome calculated for 5 years or for the actual length of the study?
Good question. For the actual length of the study, and the actual length of the study was 2.2 years. So you only have to treat 19 patients for 2.2 years to prevent one major event.
Perfect, thank you. And then just one more before we go to Gert and Christoph. We're being asked why lupus and vasculitis were excluded.
Yeah, so by the time we designed the studies, the hypothesis was that these drugs would reduce intraglomerular pressure, and we did not have solid evidence that the disease progression in lupus patients were due to increased intraglomerular pressure. In addition, we were concerned that there would be other concomitant medications that could increase the risk of infections, and we were particularly concerned that this could also, with an SGLT2 inhibitor, exacerbate infections, and therefore, from a safety perspective, we did not want to enroll these patients in the trial.
Okay, thank you. So Gert, I believe, has some slides, and he and Christoph will give us a little bit of insight into how they feel that we can interpret these results, and then we will go to the floor and try and get through as many of your questions as we can. So Gert, over to you.
Thank you very much. Try to share the screen. Just one moment. What I would like to do during the next 5 or 6 minutes is just to raise some questions that may be also of interest to the audience. And I would like to start with the first one, whether this is a class effect that we see, so that all the renal endpoints occur at the same frequency, regardless which kind of SGLT2 inhibitor we are using. This is a slide that I got from Christoph Wanner, actually. This slide summarizes the major outcome studies, be it cardiovascular studies or renal studies, like CREDENG and DAPA-CKD. And these are the results on the kidney endpoints. We have to realize that these endpoints were not defined in the same way in all these studies, but clearly there were primary renal endpoints of relevance, regardless whether we are looking at heart failure trials that mostly looked at slope changes between the active and the placebo therapy, or whether we look at the renal endpoint studies that looked like Hiddo told us before, at hard renal endpoints like end-stage kidney disease or doubling of serum creatinine. What you can see here basically is that based on the renal function at inclusion, clearly the rate of events in the treatment and in the placebo groups were different, with CREDENG and DAPA-CKD, including renal patients with more advanced disease, having much higher numbers of endpoints reached in both placebo and treated groups when compared, for example, to people. But what you also can see is that these trials that used different SGLT2 inhibitors, as you know, it was empagliflozin, canagliflozin, dapagliflozin. In general, the effect on the renal endpoints was very similar between the trials. We see risk reduction rates between 30 and about 40 to 45%, regardless which drug was used. And there is only one exception, and this is something that we may want to discuss maybe a little bit later. This is, as you know, the VERTUS trial that used dapagliflozin, where the significance for the renal endpoint actually was not reached. And this trial also differed from the other ones when you look at the cardiovascular endpoints. So this is probably the indication that maybe some of the SGLT2 inhibitors may have less protective effect. They were still safe in VERTUS. There was no safety signal. But if you look at all the other trials that used different SGLT2 inhibitors, we see a very, very homogeneous effect as far as renal endpoints is concerned. So maybe one point for discussion. The other thing is whether this is something that we can see at all stages of CKD and all different etiologies of CKD. We had the discussion with Hiddo already. There were some patients in DAPA-CKD that were excluded, like patients with polycystic kidney disease or renal autoimmune disease, for very good reasons excluded, I think, at this stage. But when you look here at the KDIGO stages from 1 to 5 and from A1 to A3, as far as albuminuria is concerned, you can see in these boxes the inclusion criteria that were used by these different studies. The renal studies, which is CREDENG and DAPA-CKD, where we already have the results available, and EMPA-Kidney, where we are still waiting for the results. And you see overall, when you take it together with EMPA-REG outcome, with CANVAS, and with the CLEAR-TIMI that had patients with very well preserved renal function, that actually these studies cover most of the aspects of chronic kidney disease, different etiologies now, as we see in the DAPA-CKD trial, with the exceptions of very, very advanced stages. However, we have to remember that advancing in stages, for example, in CREDENG or in DAPA-CKD, did not lead to the exclusion of these patients from the trials, but the treatment continued. And at least as far as I know, there was no safety signal in these more advanced stages of the disease. So probably, although the analysis is not known to me, we could also expect some renal benefit even in very, very advanced stages. So if you summarize that, you would think, yeah, most of these drugs that work via SGLT2 inhibition work in patients with kidney disease of varying etiologies and also varying stages. However, still this is from a cohort perspective. If you look at it from an individual perspective, there clearly are still some individuals that do not benefit completely from these agents. This is from Christoph's publication from the EMPA-REG outcome trial, where they were looking at the slope of eGFR loss per year, basically on an individual basis. So you can see here the percentage of patients, and this is the slope in EMPA-REG outcome trial per year of decrease or increase in eGFR in these individuals. And as you can see in the placebo group, we see this Gaussian distribution. Interestingly, many patients actually increase with eGFR over time in EMPA-REG outcome, even when they are on placebo. But there is a lot of individuals that lose eGFR to a large extent, up to 8 mils per minute per year. And in total, the mean loss of eGFR was about 1.8 mil per minute in the placebo group. And this decrease in eGFR was much less pronounced in the actively treated group. They only lost 0.3 mils per minute per year. But still, you can see that there are some individuals that had huge benefits in the active treated group, clearly more than in the placebo group. But then again, if you look at the other end, there are still some individuals that still lose a lot of eGFR. I would not call them non-responders because we do not know whether these individuals wouldn't have lost more, even more eGFR if they were not treated with dapagliflozin. But these individuals here on this part of the slope, I think they still need additional therapy. So it's great work that has been done. We have made great achievements, but still there's a lot to do, because we also should try to avoid the decrease in eGFR in these individuals as well. And the final question that I would like to pose, and maybe somebody would like to answer on that, is maybe something that is a little bit provocative. This is an analysis that we did also together with Christoph from the EMPA-REG outcome trial, where we again, like Hiddo mentioned, also we are looking whether co-medication could affect the efficacy of dapagliflozin in the EMPA-REG outcome trial. And in contrast to DAPA-CKD, where Hiddo told us that 97% of these individuals were on kind of RAS-blocking therapy, in EMPA-REG outcome, there was actually a quite large fraction of individuals that did not receive RAS-blocking therapy. There were more patients on RAS-blocking therapy, but still a considerable amount of subjects was not on RAS-blocking therapy. So these individuals were only receiving SGLT2 inhibitors. And we did an analysis looking at the eGFR slopes in individuals that were not on RAS inhibition and on placebo. This is this line, and this line, the red line, are those individuals that were not on RAS-blocking therapy and they received dapagliflozin. And on the bottom, the dashed line shows you parallel those individuals that were on RAS-blocking therapy but received placebo, and those, the raised dashed line, RAS blocking therapy plus SGLT2 inhibitors. The first thing that you can see is that the subjects on RAS blocking therapy had slightly lower eGFR than the patients not on RAS blocking therapy, but that's not the point that I would like to make now. Let's just look at the slopes of the different groups. The placebo group in the patients that only had dapagliflozin and received placebo and no RAS blocking therapy, there was this slope. This was parallel to the slope in the individuals on RAS blocking therapy and on placebo as far as dapagliflozin is concerned. But the interesting point actually is those individuals that had no RAS blocking therapy and only received dapagliflozin, they had a complete stabilization of eGFR over time, which was again in parallel to the ones that received combination therapy. So if you would like to make this interpretation, you could argue that complete stabilization of eGFR is possible with these agents, even in the absence of RAS, which leads to the question whether we still will need RAS blocking therapy in the area that we use SGLT2 inhibitors. Keep in mind, this is a secondary analysis. This was not done for that purpose, but it's, I think, something that at least could lead to some discussion. So thank you very much, and let's hand over to Christoph or Kate.
Yeah, so thanks, Gert. So if you don't mind, we've had lots of questions, so I'd like to tie in some of your controversies and see if we can tie them into some of the questions. So Christoph, if I could go to you first of all, please. So SGLT2 inhibitors have a hemodynamic effect, and you see a drop in GFR initially. So with RAS blockade, we would advocate checking renal function. Do you think that, given what Gert's discussed, we should be advocating that with an SGLT2 inhibitor we check renal function, or do you think that that might lead to people stopping the SGLT2 inhibitors unnecessarily when they see the dip?
Very good question and discussion currently. And the consensus was already reached among some of the experts saying, don't measure too often creatinine because it will stabilize and you will see a return to a higher GFR and after a couple of weeks, as we have seen in the trials. And important is that we do not really see acute kidney injury. A meta-analysis of at least the first 4 trials show even a protection of investigator-reported acute kidney injury. So people like to hear this. Cardiologists have taken up this message. Don't measure creatinine too often because this makes it easy to follow the patient, and otherwise it's too busy to bring him back like with RAS blockade after 10 days to measure creatinine and potassium. And I hope that this consensus will hold when we do better analysis. But this is the message currently out there, and people like it. Don't care about the dip.
Don't do too many blood tests. That sounds perfect. So another question on a similar line. So I'm going to read you the question. I think ACE inhibitors and ARBs remain indispensable because more than 80% of these patients are hypertensive. So Christoph, if I could ask you first of all, what's your opinion about that?
I think Gert has also an important opinion. He has studied this. I think a combination therapy is absolutely appropriate, and we may have a polypill in about a couple of years, 10 years.
Gert, do you have anything to add to that?
Can I respond to this as well?
Oh yeah, sure. So we'll go Gert first, then Hiddo. That's great.
Okay. I would agree with Christoph's remark, but there may be a subset of individuals that prone to acute renal failure on ACE or ARB therapy, but stable, for example, on other antihypertensive therapy like calcium antagonists or beta blockers. So this may be a subpopulation where this question really is of relevance, whether we need combination therapy. In many of the other people, I think it's clear that just to keep blood pressure under control, RAS blocking therapy is still gold standard for these individuals.
And Hiddo?
Sorry, my internet is unstable.
No,
I can just add that we did an analysis in the CREDENG trial where we looked at patients with refractory hypertension, and we found that adding SGLT2 inhibitors to these patients significantly reduced blood pressure. So I agree with the comment made by the person. I think that we also should add SGLT2 inhibitors because they also reduce blood pressure, even in patients with refractory hypertension.
Yeah.
So, Hiddo, is this effect so prominent because you are desalting the individuals with your SGLT2 inhibitor?
Yes, very good question, Christoph. We just presented the results of the DAPA-CKD study, which is a study where we looked at in carefully controlled settings at sodium excretion. So we asked our patients with type 2 diabetes with preserved kidney function to collect 14 24-hour urines in a row to establish baseline sodium excretion, and then we had expected an increase in sodium excretion, but we didn't see an effect on sodium excretion. We then repeated the study in patients with non-diabetic kidney disease, and again, we didn't see an increase in sodium excretion. This is very surprising, and I believe that there is still inhibition of sodium reabsorption in the proximal tubule, but then there's so many compensatory mechanisms in the distal tubule that you don't see an effect on sodium excretion. So I don't think this is desalting of the patient, but I think there's other mechanisms that play a role.
Hiddo, could I ask you a couple of questions about the study participants, please? What was the lowest GFR in DAPA-CKD?
We enrolled patients with the eGFR down to 25 mL per minute. There were 632 patients with the eGFR between 25 and 30. And the effects of SGLT2 inhibitors in this specific population of stage 4 CKD were consistent compared to the other population. The safety was also well established, and again, there was no safety signal in this population. And finally, important to remember that these patients continued on dapagliflozin all the way until they reached dialysis. In fact, it was not mandated to stop dapagliflozin if patients reached dialysis. So there are a number of patients in dapagliflozin who continued dapagliflozin even when they were on dialysis. And we're currently analyzing those data as well.
Okay, and then what was the average BMI of the patients? Do you have that information?
On the top of my head, 29, but maybe 30, but that's approximately the BMI.
Because you had a lot of Asians in your trial, otherwise your BMI should be 32.
Correct, but we also had non-diabetic patients, and the IgA nephropathy patients have a lower BMI.
Yeah. Okay, so one more for you, Hiddo, and then I want to change tack and ask Christoph something. So one of the exciting things about DAPA-CKD is the large proportion of patients with IgA nephropathy as primary renal disease. So should we be using DAPA in people with IgA nephropathy?
I love the question, and I'm delighted to answer that next week at the ASN, we will present the results of dapagliflozin in that specific population. And I want to tell you the results, but I have to keep my mouth shut until next week.
Go on, tell us.
But listen to that presentation next week, Friday, 11:30 US Eastern time. So in Europe, 16:30. Listen to the presentation because the results are
next Friday, ASN.
Very exciting.
Okay, perfect. We will do. Okay, so changing tack, Christoph. How do you explain the negative effect of ertugliflozin?
There is no explanation. Nobody can explain. Actually, most experts say it's not a negative effect. The point estimate is on the left side. The study was just unlucky that the confidence interval was crossing the unity. There are some hypotheses out there that the population is not so homogeneous in Vertis as in other trials, because Vertis could have divided into 2 studies because they had 2 different recruitment times, but the company already did this analysis that the 2 groups actually are looking the same. So you can speculate around. I think it's not the molecule. It's not, so actually we do not know. But Hiddo, you are involved in these discussions. Do you have something to add here?
Maybe I can add, there was a presentation at the EASD, and the endpoint, as Gert already mentioned, the kidney endpoint in all these trials differ a little bit. And it also differed in Vertis. The endpoint in Vertis was a doubling of creatinine, but the doubling of creatinine did not have to be sustained. Usually in clinical trials, we ask that doubling be sustained so that we are sure that we're looking at chronic kidney disease progression. This was not the case in Vertis. When they did a post-hoc analysis and looked at sustained doubling of creatinine, they found this fewer endpoints, but the effect of dapagliflozin was statistically significant and in line with the effects seen in other trials.
So, Kate, can I have a question to Hiddo about Gert? Your meta-analysis you showed can be criticized, and Hiddo is a trialist, and I want to have his criticism whether we can do these types of comparison between trials where we have different endpoints investigated, or do we have to wait for individual data meta-analysis?
Yeah, that's a good question, of course, Christoph, and we have to be careful. It depends a little bit whether we first want to look at the overall effect and then demonstrate if there's heterogeneity in the effect, and if there's heterogeneity, explore the heterogeneity, so the difference across trials, and whether we can explain that by baseline characteristics. In this case, Gert beautifully presented the strong effect of all SGLT2 inhibitors, regardless of the population we're looking at, be it patient with type 2 diabetes, preserved kidney function, reduced kidney function, diabetics, non-diabetics, patient with heart failure. Actually, in all these trials, we see a consistent effect. So it's likely that SGLT2 inhibitors are actually beneficial in all these different patients, but we also always have to realize that we are looking at different populations. Then does the question posed by Gert, is this a class effect or is this a specific drug effect? To me, it's a class effect, but from a clinical perspective, I would always select a drug with a proven efficacy on clinical endpoints. And for treating chronic kidney disease in the non-diabetics, dapagliflozin has proven it. The other drugs have not yet proven it. I hope EMPA-KIDNEY will show similar results, but for now I would select dapagliflozin because of the proven efficacy. But maybe Gert, you want to express your views on this class effect issue.
I also agree. From a pathophysiology point of view, I think it's quite reasonable to expect a class effect on this. I just have also one question. Is that possible, Kate?
Yes, I've got 26 from the audience, but yes, you can ask.
Okay. just one short question, Hiddo. If you look at the eGFR over time in diabetics and non-diabetics, you showed us the summary slide for both populations where you see the dip. Is there any difference in the dip between CKD and DKD, or is it the same drop in both entities?
It seems to be the same drop in all the diseases. And that's what we also saw in Diamond. Measured GFR dropped by 6.6 mils per minute, and that seems to be consistent.
Okay, thank you. So can we change tack slightly and talk about the metformin controversy? So metformin obviously is advocated as first line, I think by everyone apart from the European Society of Cardiology. And there's now the suggestion that we should be offering SGLT2 inhibitors as first line as opposed to add-on, or because metformin has failed. Would you like to pass comment on that, please?
Just a quick comment. We published 2 days ago in the journal Diabetes, Obesity, Metabolism, a big meta-analysis where we looked at all the effects of SGLT2 inhibitors in patients with or without concomitant metformin use, and we found it on all different endpoints, CV endpoints, heart failure, kidney failure, mortality, effects were consistent or even better in people not using metformin. So to me, I think these drugs are definitely beneficial also when you're not using metformin. And we know that in some people with a low GFR, metformin cannot be tolerated. And I think that SGLT2 inhibitors would then really be a good alternative, but definitely can also be added on top of metformin.
So Hiddo, then let me be a little bit naughty. If you had diabetes and a bit of CKD and they offered you medicine, which would you take, SGLT2 inhibitor or metformin?
What do you think?
What do I think?
Yeah.
I think you'd take an SGLT2 inhibitor.
Look at my enthusiasm, yes. SGLT2 inhibition.
but KDIGO is looking also on countries in this world where the resources are not so high and metformin is cheap and we have long experience. So why not combining? Yeah. Okay.
So a combination. Now, I think we've had a question about the effect of SGLT2 inhibitors and their effect on potassium. Am I right in thinking potassium neutral? Is that correct? They don't cause a rise in potassium?
No, and even some studies have shown that they decrease hyperkalemia incidence. So they maybe even, and that's why we're doing a study with combined mineralocorticoid receptor antagonists in combination with SGLT2 inhibitors to find out if we can perhaps even mitigate the hyperkalemia with the combination therapy.
Okay, so we've had lots of questions about the side effects of SGLT2 inhibitors. So I guess the main ones are amputation, so from way at the beginning. And I think there's probably reasonable evidence now that they don't cause an increased risk of amputation. Also about, question relating to the use of them in combination with statins and whether or not there might be an increased risk of rhabdomyolysis. And then also regarding the euglycemic acidosis that we see and whether or not we should be thinking about sick day rules and firm sick day rules. So if perhaps, I don't know if Gert, you would like to comment on the side effects of the SGLT2 inhibitors?
Actually, if you look at this, the study results, they seem to be extremely safe and very little side effects. I'm actually a little bit surprised to see this placebo-like genitourinary infection complication in the studies. This is not what we see in clinic completely, okay? This may be that the patients that go into a study get better education on what they should take care of. And we know that patients in studies generally do better than patients in clinical practice. But this is the side effect that I think is, from a clinician's point of view, the most frequent side effect that we see. We have never seen, but Hiddo has a better view on that because he knows the data better, any indication that there may be an interference with some kind of statin to cause rhabdomyolysis, because I think that the cytochrome P450 interaction is not a problem with these combination drugs.
This is the first time I've heard about it, and I'm not aware of any interaction with statins. No.
Okay, perfect. What about your thoughts about using SGLT2 inhibitors in patients who have type 1 diabetes and a low BMI, and similarly in just patients generally who are not obese?
Christoph
or Hiddo, I don't know if you like
there are studies in type 1 diabetes. The diabetic ketoacidosis risk is twice as high. We do not pursue the recommendation in the moment. Also, there are some patients type 1, they are on SGLT2, lower dose according to trials, but they are very well educated people. They have their diabetes under control. They know how to handle insulin and so on. But overall, it's not a general recommendation so far.
Okay.
I would agree.
Okay. What about any information in individuals who are of African descent? Do we have any information about the use of SGLT2 inhibitors in this group?
Yeah, the CREDENG trial enrolled about 5% of patients with African-American descent, and the same proportion was involved in DAPA-CKD. There was no suggestion that the effects of SGLT2 inhibitors were different in these populations. it would be nice to do a meta-analysis across the trials in that specific population because the proportions are relatively low. It's still an important patient population. Probably we can do that in the future. But for now, there's no suggestion that there's no benefit for these patients.
Okay, thank you. And then we have a little, so we're nearing the end actually, so let's finish on a couple of controversies. So from the audience, what will happen when Dr. Bakrish shows us the results of the Fidello study, so looking at finerenone in the ASN or at the ASM. So SGLT2 inhibitors were not used in this study, and we don't have any studies comparing the two pharmacological groups.
Yeah, we have 5% of patients with mineralocorticoid receptor antagonist, and I already gave you a preview. Effects were consistent by background MRA use. We'll show those data at the ASM next week. The other way around, finerenone, a Fidelio trial, enrolled 5% of patients with SGLT2 inhibitors, so hopefully they will present their results in that subgroup. In addition, we have just completed the recruitment of a trial where we compare head-to-head eplerenone with SGLT2, and then in the third treatment period do the combination. We hope to finish the trial in the next 7 months or so, and then we have a head-to-head comparison and the combination. So in the near future, we'll have more data on eplerenone or mineralocorticoid receptor agonist and SGLT2.
Perfect. So Maria Soler is commenting that the blood pressure was different between the non-diabetic and the diabetic patients in DAPA-CKD. Do you think that matters?
Yeah, well, good point. I mentioned that the results were overall consistent, but actually, if you look carefully in the patient with a low blood pressure at baseline, less than 130 millimeter mercury systolic, there was a larger effect compared to a patient with a higher, although the effect was present both in people with low or high blood pressure. Well, it could be that this is a reflection because patients with a lower blood pressure were more likely to have non-diabetic kidney disease, and we also showed that there was a tendency towards a larger effect in people with non-diabetic kidney disease. So yes, non-diabetic kidney disease patient had a lower blood pressure. Effect is still present in those patients for sure.
Okay, and then Gert, would you recommend using an SGLT2 inhibitor in a patient with CKD who does not have proteinuria?
That's a tough one, huh? Because you know I'm actually still wondering whether individuals with quote unquote pure hypertensive renal disease, so you have afferent arterial disease. The afferent arterial does not dilate, and probably the pathophysiology of resulting kidney disease is different from CKD patients. And one manifestation of this form of disease, as we all know, is very low-grade proteinuria. And this is something this will be really very interesting. I have no idea currently, and I would not use it in these individuals.
Okay. Christoph? Would you use it in non-proteinuric patients?
Yeah, for this reason, we enroll these patients in DAPA-CKD trial, and there we will get the answer. You have to wait.
Okay.
And because Gert was hesitating and many others, we increased the number of patients going into DAPA-CKD to balance maybe an effect in this subgroup.
But okay. Christoph, if my neighbor comes to your office tomorrow, he has non-diabetic kidney disease with microalbuminuria. And he says, well, my neighbor Hiddo has shown these results. Can I get dapagliflozin from you? What do you do?
Hiddo, this is tough because I'm within DAPA-CKD and I cannot recommend this because I would blow up my trial.
Then I'm going to ask Gert.
My brother, yeah, okay, thank you.
Okay.
Okay, so we need to tie up. I'm going to ask one more question. So I'm going to put this to you, Christoph, please. How do you see cardiovascular death reduction heterogeneity across different uses of SGLT2 inhibition? So for example, patients with type 2 diabetes, people with heart failure, people with CKD who are on SGLT2 inhibitors. Is there a difference in terms of the cardiovascular benefit in these different populations?
I did not think this this answer through because there's difference in cardiac death, and EMPA-REG outcome was so prominent with cardiac death, and then you go to the heart failure, and then you have opposite signal in the various trials. It's not an anti-atherosclerotic drug. When you have adjudication of endpoints, when you mix, maybe you have some more sudden death in this, more heart failure in this subcomponent. So you have different risk within these cardiovascular outcome trials. You have one with multiple risk factors with established cardiovascular disease, and therefore you have heterogeneity in the results. So that would be my short answer.
Okay, and then Hiddo, final question for you, an easy one I hope. Can you use SGLT2 inhibitors in liver disease, so in hepatorenal syndrome or liver cirrhosis patients?
There are some studies that suggest that SGLT2 inhibitors improve liver function, and the mechanisms by which they improve liver function are not completely understood, just like the mechanisms how they improve heart failure or kidney failure. But yes, this is an area of active research. I think the larger trials have to be conducted to definitely prove that they improve liver disease outcomes. So for now, I'm not sure if I would do it, but hopefully those large trials will be finished. But it seems that it is effective. And that could reflect the metabolic effects of SGLT2 inhibitors and beneficial metabolic effects.
Okay, so I'd like to tie things up, please. So thank you very much, Hiddo, Gert, Christoph. So that was a fantastic presentation and then a superb discussion with an awful lot of questions. We haven't managed to get through all of them. And what I'll maybe do is, if it's okay with you, maybe we can post them on our website with some answers a wee bit later on. Everybody should tune in next Friday, 4:30 European time, to Hiddo's presentation. Find the answer for nephropathy and SGLT2 inhibitors. And if you haven't managed to catch everything today because you had other things on, or if any of your colleagues want to watch this seminar, it will be on YouTube. And thank you very much indeed. That was great.
Thank you, everyone.
Thank you.
Thank you.
Bye-bye.
Bye.